Okay, so now we're going to talk about Chapter 4, Upper Respiratory Tract Dysfunction. This is going to be Part 1. Infections of the respiratory tract are described according to the anatomic area of involvement. However, respiratory infections seldom fall into discrete anatomic areas. Infections often spread from one structure to another because of the contiguous nature of the mucous membrane lining in the entire tract. When you look at the general aspects of the respiratory system of the pediatric patient, respiratory rates are higher in children. The diaphragmatic abdominal breathing is also common in infants. Oxygen consumption is high in children in proportion to body size. Metabolic rate is higher than in adults. The airway diameter is smaller in children, which increases the potential for obstruction. Mucous membranes of the airways are highly vascular and are susceptible to trauma, edema, and spasms. Surfactant is lacking in preterm infants, which contribute to respiratory distress syndrome. Accessory muscles of respiration are not as strong in children, particularly in the infants, and the chest wall retractions are common in infants with respiratory problems because the chest wall is supple. Infants less than 3 months, they have maternal antibodies that help protect against respiratory tract infections. 3 to 6 months, the infection rate increases. Toddler and preschool ages, there's a high rate of viral infections. Greater than 5 years, there's an increase in mycoplasma pneumonia and B. hemolytic streptococcal infections. They have an increased immunity with age. You want to see box 40-1 on page 1196 of your textbook and look at signs and symptoms that are associated with respiratory infections in infants and small children. Also take a look at box 40-2 on page 1197 of your textbook and review components for assessing respiratory function. Okay, so let's look at some nasopharyngitis. Also, the pathophysiology, its common name is known as the cold or as an acute coryza. Most common infection of the respiratory tract. Causes could be viruses such as rhinoviruses, RSV, adenoviruses, enteroviruses, the influenza virus, and parainfluenza virus. It's spread by coughing, sneezing, or direct contact. Susceptibility, it depends on and is affected by age, the general health of a child, their health history, were they a preterm infant, and then of course their level of nutrition. Symptoms can include fever as high as 104, and then in children less than 3 years of age, and then older children may actually have a low-grade temp. There could be nasal discharge, irritability, sore throat, cough, general discomfort, and or nausea and vomiting. You want to take a look at box 40-3 on page 1200 of your textbook. Diagnosis can be complicated because of many infectious diseases that resemble nasopharyngitis during the onset of the infection. Complications that can arise are bronchitis, pneumonitis, and ear infections. Okay, so what can be the treatment and nursing care? They need rest. Prevention of fatigue is very important. Bed rest is advised, although child should be allowed to play, such as play therapy, which promotes minimal activity but allows the child to physically rest also. Activities should be age and developmentally appropriate. Airways. You need to suction before feeding and bedtime using saline drops and a bulb syringe. Deep suction is not typically indicated. You want to avoid use of oil-based nose drops to help prevent aspiration and respiratory problems. For fluid intake, encourage adequate fluid intake. Cool, bland liquids are typically tolerated well. Encourage intake of Pedialyte to prevent dehydration and electrolyte imbalance. For fever, may administer Motrin and Tylenol, and they can alternated for high fevers. Skin care. Have the parents apply a petroleum-based ointment such as Vaseline to the nares and upper lip to prevent skin irritation from nasal discharge. Humidification. Moist air soothes the inflamed airways. An electric cold air humidifier is safe to use but must be emptied, cleaned, and disinfected daily. Taking a child in the bathroom and running a hot shower with the door closed and a fan off, not placing the child in the shower, may actually produce a similar effect. Provide education, especially hand washing. Teach older children proper way to remove nasal secretions from the nose. Open their mouth slightly and gently blow through both nostrils at the same time. It helps to prevent infection from being forced into the Eustachian tube. Teach children to cover their mouth and nose when coughing or sneezing to help prevent the transmission of infection. Like we discussed earlier about medications, Tylenol and or Motrin can be used for fever. Antibiotic therapy is not indicated. It's a viral infection, remember? So vasoconstrictive nose drops such as Nasopharyngitis should not be used for more than 3 days to avoid rebound congestion. Drops should be discarded after one illness because they may become contaminated with the bacteria or the virus. Drops administered before feedings are more helpful, and also over-the-counter medications, cold preparations such as cough and cold, Dimetapp, etc., should be avoided unless ordered by the pediatrician. This is a great hand washing visualization that can help children understand what happens if they don't wash their hands. Okay, for acute pharyngitis, pathophysiology, inflammation, of the structures in the throat. It's common in children between the ages of 5 and 15 years. The most causative organism is group A beta hemolytic strep in about 20% of the cases, viral in about 80% of the cases. Haemophilus influenza is common causative organism under the 3 years of age. Symptoms usually include dysphagia, fever, malaise, and anorexia. Diagnosis is difficult to distinguish between viral and bacterial by symptoms only. Then we have conjunctivitis, rhinitis, cough, and hoarseness with a gradual onset and persisting no longer than 5 days, which is characteristic of viral pharyngitis. Greater than 2 years of age, streptococcal is typically includes a high fever and dysphagia and may last greater than 1 week. It's determined by a throat culture through a rapid strep test. Complications can include rheumatic fever if the strep is left untreated, glomerular nephritis, peritonsillar abscess, otitis media, mastoiditis, meningitis, osteomyelitis, or pneumonia. Treatment and nursing care would include for fever, Motrin and or Tylenol that can be alternated for the high fevers. Fluid intake, you want to encourage adequate fluid intake. Encourage intake of Pedialyte to prevent dehydration and electrolyte imbalance. Medications, like I said, Tylenol or Motrin for fever. Antibiotic therapy indicated with a positive strep culture. Typically, penicillin is given by mouth for 10 days. Erythromycin is given if they're allergic to penicillin, and Tylenol can be given for soreness or pain in the throat. For comfort, if the child is old enough to gargle, have the child gargle warm salt water to help relieve the soreness. Education, you want to teach parents importance of completing prescribed therapy to prevent serious complications. The child may return to school or daycare after a full 24 hours on the antibiotic and once they are afebrile. You want to have a follow-up. The child may persistently have a positive culture for strep A, which can mean the child is a carrier or that the child did not finish the full course of antibiotics to treat the infection. Okay, so let's talk about tonsillitis and adenoiditis. Basically, the pathophysiology is an infection, inflammation of the tonsils or the adenoids in the pharynx. So it can be bacterial or viral. Symptoms usually include dysphagia or dyspnea, and that's usually caused from enlarged adenoids that block the nasal airway and result in the mouth breathing. They also have signs or symptoms of nasopharyngitis. Some complications could be bronchopneumonia after usually about 72 hours, which can cause atelectasis. And typically for medications, they don't normally use antibiotics unless there's a confirmation of strep. If indicated, there will be surgical treatment, which is the removal of the tonsils and the adenoids. It's not recommended for children that are under the age of 3. It's indicated with recurrent episodes of tonsillitis with restriction and or obstruction of the airway. Surgery is not performed during times of infection or inflammation and because the tissue will actually not respond well. For education, you want to teach kids about their surgery a couple of days in advance, not the day of and not weeks before. You want to teach parents to be open and honest and encourage the child to address fears. Explain anesthesia in a way that the child can understand it, calling it like put to sleep, or make the child think that they will not wake up and increase their stress level. Advise parents that it is an outpatient surgery and let the child know that they will return home after the procedure. Also be sure to ask parents and or the child if indicated about the loose teeth during anesthesia that can actually easily be knocked out and can actually cause aspiration or pneumonia. You want to make sure they're aware of this. For post-op, you want to place the child lying partly on the abdominal to facilitate draining. You want to assess for evidence of bleeding. You want to watch the child closely. You want to check for excessive swallowing, which often indicates bleeding. Small amounts of clear liquids are given. Typically, the child is rewarded with a popsicle postoperatively. Do not give any liquids with red coloring in them because then you won't be able to assess for bleeding appropriately if they do. You want to keep the child quiet for the day. This is usually not difficult considering after having a tonsillectomy or adenectomy. The child should avoid coughing, clearing the throat, or blowing their nose, which can cause bleeding. Some complications can be hemorrhage. That's the most common post-op complication. For discharge, you want to provide parents with verbal and written discharge instructions. The child should be kept quiet for a few days, and the child should be provided ample nutrition with a diet progressing from clear to soft by the end of the first or the second day. The diet should be bland for the first post-operative week. Avoid highly seasoned foods. Also, they should avoid milk products post-op that can lead to coating on the throat, which may stimulate the child to have to want to clear their throat. And then, of course, no potato chips or anything that is hard to eat. This concludes part 1 of respiratory dysfunction in the pediatric patient.